Imagine two patients arriving at the emergency department with the same clinical finding, exactly 1 liter of air trapped in the pleural cavity. The first patient is a tall, 20-year-old male with no history of lung disease. His condition is a primary spontaneous pneumothorax, caused by a single apical bleb that has ruptured through the visceral pleura. The second is a 70-year-old male with severe COPD. His lungs are compromised by diffuse, thin-walled emphysematous bullae, creating a landscape of structural weakness. Despite having the same volume of ectopic air, these two presentations require different management strategies. The intervention is determined by the integrity of the lung tissue, not just the presence of the air itself. To determine the correct course of action, clinicians rely on a matrix of 3 factors: etiology, hemodynamics, and the severity of the patient's symptoms. Etiology defines whether the lung was healthy or diseased before the collapse, while hemodynamics differentiate a stable, simple pneumothorax from a life-threatening tension event. By deconstructing the physics of the pleural space, the protocols established by the British Thoracic Society and ATLS become predictable outcomes of anatomical mechanics. Understanding this matrix is the first step in moving beyond the air leak to address the physiological environment containing it. A primary spontaneous pneumothorax occurs when air enters the pleural space from a breach in otherwise healthy lung tissue. This is most common in young, tall individuals where mechanical shear stress is highest at the lung apices. In healthy parenchyma, a tissue retains its natural elasticity. When a small bleb ruptures, the surrounding healthy tissue can contract and seal the breach, often allowing the lung to heal on its own. A secondary spontaneous pneumothorax occurs in a lung already weakened by diseases like COPD or fibrosis. This diseased tissue lacks the elasticity to close a leak. When a bulla ruptures, the defect remains open, causing a persistent air leak. Because of this structural failure to heal, secondary spontaneous pneumothoraces have a significantly higher recurrence rate within the first year compared to primary events. Patients with these chronic conditions have very little pulmonary reserve. This means even a small volume of air in the pleural space can lead to rapid and severe physiological collapse. In a trauma setting, the suspicion of a tension pneumothorax triggers an immediate response, often before a chest X-ray can be performed. This condition is caused by a one-way valve mechanism. Air enters the pleural space during inspiration, but is unable to exit during expiration, which causes intrapleural pressure to climb. While it is a respiratory injury, the primary cause of death is actually obstructive shock. As pressure builds, the mediastinum shifts to the opposite side. This compresses the superior and inferior vena cava, blocking blood return to the heart. This compression blocks the blood from entering the heart, which causes preload and cardiac output to drop, resulting in a rapid and fatal decline in blood pressure. To restore circulation, ATLS guidelines call for immediate emergency needle decompression using a large bore needle. The current recommended site for this decompression is the 4th or 5th intercostal space, located between the anterior and mid-axillary lines. This landmark replaced the older 2nd intercostal space because of the high failure rate associated with thick anterior chest walls, which often prevented the needle from reaching the pleural space. Needle decompression provides a vital bridge. It relieves the pressure and restores venous return, providing the time needed to set up a formal, definitive chest drain. In stable patients, the diagnosis is confirmed using a posterior-anterior chest X-ray, which allows for precise measurement of the pneumothorax. Guidelines specify measuring the distance from the edge of the lung to the chest wall at the level of the hilum. A distance of 2 centimeters is the threshold used to guide management. For a primary spontaneous pneumothorax, a patient with a rim of air smaller than 2 centimeters and no symptoms can be managed with observation and high-flow oxygen to help the air reabsorb. If the primary pneumothorax is larger than 2 centimeters or the patient is symptomatic, needle aspiration is the first step. If aspiration fails twice, a small bore chest drain is inserted. This conservative approach is not used for secondary spontaneous pneumothorax. Because the lungs are already compromised, needle aspiration and observation are not recommended. A secondary pneumothorax in a symptomatic patient requires a small bore chest drain and admission to the hospital for monitoring. There is also a specific risk on the ward for patients with COPD who are receiving non-invasive ventilation, such as BiPAP. The positive pressure from the machine can act as direct barotrauma, forcefully causing a thin-walled bulla to rupture. Clinical guidelines for these patients are a practical translation of this underlying tissue vulnerability. Before a patient can be discharged, they must show complete clinical recovery, a stable chest X-ray, and pass a 4-hour observation period after their chest drain is removed. Even with a clear X-ray, the lung remains vulnerable to changes in atmospheric pressure. Patients are advised to wait 1 to 2 weeks before flying and to avoid driving until they are no longer in pain. For recreational scuba diving, the British Thoracic Society indicates a permanent, lifelong contraindication following any spontaneous pneumothorax. This is explained by Boyle's law. As a diver ascends and the surrounding water pressure decreases, the volume of any trapped gas increases. Along with a closed bleb, this expansion can cause a catastrophic rupture. The only exception is for patients who have had a bilateral open surgical pleurectomy and can prove they have normal lung function through testing. While the lung may look resolved on an X-ray, it can still be susceptible to the physical stresses of changes in environmental pressure. If a chest drain fails to stop an air leak after 72 hours, or if a patient experiences multiple collapses, they are referred for surgery. Video-assisted thoracoscopic surgery, or VATS, is used to perform an apicectomy and a pleurodesis. During these procedures, the surgeon removes the damaged tissue and causes the lung to bond directly to the chest wall, which eliminates the pleural space. Managing a pneumothorax is a process of balancing the structural integrity of the lung against the pressures of the environment and the cardiovascular system.